We thought we ought to finish off the theory block that relates to the O2 course. And then when life returns to a little bit more normal, we can do the practical elements. So this is going to be entertaining because I've got proper medical people. So it's going to be entertaining doing it this way. But anyway, away we go. You've undone me again, Robin.
I haven't. Go on. That's it.
Okay.
There is a slight delay, Gareth.
So what we're going to do is we're going to cover what is oxygen, and then we're going to look at some diving-related injuries and how oxygen works with those. So that's decompression illness, burst lung injuries, near drowning, and I know this will amuse our medical friends, shock. Carbon monoxide poisoning, and then we're going to look at some signs and symptoms and some on-site first aid stuff. So, and particularly the benefits of oxygen. And I know this is one of those lectures which sounds quite negative because it's all the things that can go wrong rather than the nice aspects of diving. So if I move on to the next one. So I know Paul mentioned this in one of his little presentations. Characteristics of oxygen are colourless, odourless and tasteless gas, which basically means you have absolutely no clue you're breathing it because it tastes, smells and looks exactly like air. So there's that. It comprises approximately 21% of the atmosphere, or that's how we always teach it in the diving training world. And most importantly, it's an essential component of metabolism. So without oxygen, we die. Oh, woe is me. And it's carried in the bloodstream. Now, that's the interesting bit because it's primarily combined with hemoglobin, which is, and about 98.5% of the oxygen circulating is bound chemically to hemoglobin, in oxyhemoglobin, and the other 1.5% is dissolved into the plasma or the remaining fluids in the blood, which we'll come back to a little bit later. So as I say, the plasma and the other bits of the blood have the ability to, we can use that when we use the oxygen administration equipment. It will not burn on its own, but it does support combustion. And again, that was a point that Paul made a couple of weeks ago, that O2 in itself isn't a problem, but if you put it near something that will burn with a source of ignition, you get quite a vigorous flame or vigorous burning. So, number one, decompression illness. So, causes. Guess what the causes are? Inadequate elimination of nitrogen from the body during ascent. If you want to be pure about it, any inert gas that you've absorbed into the tissues, like helium if you're doing that type of diving. You can get it from physical damage to the alveoli due to overpressures. So what we're talking there really is if you hold your breath during an ascent, then you overpressurize the alveoli and you get air emboli into the bloodstream and they circulate around. So you force bubbles of gas into the bloodstream. Not a good thing. And the problem with that is you either get bubbles forming in the surrounding tissue that restrict blood flow through the blood vessels, or you get the bubble nuclei in the blood vessels themselves, and they cause problems with reducing the ability of the blood to circulate past where the obstruction occurs. So bubbles blocking blood flow, and bubbles in tissues compressing the blood vessels themselves.
Can I ask I don't mean it be a stupid question.
Yeah.
Just to clarify, we talk about pressure introducing bubbles of air into the blood.
Yes.
But when we're normal breathing, right, and the normal transfer takes place, we're getting more or less air or the components of air into our blood anyhow, aren't we?
Yeah. The overpressurizing one really is the don't hold your breath when ascending. So, you know, fast ascents and people holding their breath, which are sort of the classic panic issues that you potentially may be dealing with, is where you're going to get those types of problems. So, and the other one here we've got, I always say this wrong, I always just say PFO, but if the non-medical ones of us, when you're born, well, just before you're born or when you're born, you actually have a hole in the heart that allows the blood to circulate independent of the lungs when you're in the mother's womb. And then very slowly after you're born, that hole closes up in the majority of the population. Some people always have a hole in the heart. So that allows, if you like, nitrogen-loaded blood that should be going from the heart back to the lungs to have the nitrogen eliminated and then new oxygen brought back in. If you've got a hole in the heart, there's a potential risk of the blood shunting across the heart to the other side, taking that high gas load of nitrogen into the circulation system. And then you've already got, if you like, micro bubbles circulating back round that are becoming even bigger because they're getting more nitrogen as they go back around the body again. So that's why PFOs in particular are an issue. So carrying on the decompression illness, signs and symptoms. Right. The first one, which is really, really an issue with most divers, is denial. Most divers will come up with any excuse as to why they haven't got a bed. And part of that is obvious. We'll come back to that maybe in a little while. The classic ones are skin itching or rashes or mottling of the skin, which is basically what they call skin bends. Numbness, tingling, and joint pain, which is where the phrase "the bends" comes from, because bending the joint reduces the pain. And then we get on to nervous system type ones, which are disturbance to vision, dizziness, nausea, headaches, confusion, loss of balance, weakness, paralysis, loss of bladder, bowel control. And I know that is a problem with divers generally after a night out in the pub. Shortness of breath, because obviously you've got breathing problems added. Oh, we've got another individual coming.
Let them in.
There we go. Shock and unconsciousness. I'm at the corner of my eye. I can see one smiling every time I say the word shock. Just to sort of give you a little bit of a feel, 75% of bends generally are what they classify as severe, which were probably what they call type 2 bends, which affect the nervous system. 35% generally are minor, which is your joint pain and your skin rash. And of course, these can get progressively worse. So a type 1 bend can become a type 2 bend quite quickly. And these days, we don't tend to differentiate the type of bend someone has. We just say they have a bend, send this person to the medics, and they'll find out how bad it is and deal with it as such. The other thing is generally 50% of bends will occur within the first 30 minutes of surfacing if they didn't occur in the water. And that generally, if they've occurred in the water, will be people doing extreme dives in either terms of depth or duration. And 85% will normally occur within the first hour and 90-odd% within the first 3 hours. And then 99% within the first sort of 6 hours or so. And then, you know, the interesting thing is that from statistics, it takes quite often 3 days before a diver will actually admit they're bent. And by that time, you've done quite a lot of damage to yourself. So the earlier you get treated, the better. And basically, any abnormality after a dive. Now, I know with some members of the club, they have a lot of abnormalities after dives, but we'll brush that to one side. That's a little comment about when they... So, on-site first aid. Lie the casualty down flat. And again, if you remember Paul's lecture, made a point of saying the casualty should be either flat or in the recovery position. And again, that means not sitting up, which if you've watched any of the RNLI programs, they get really irritated when they see divers sitting up when they're coming in to collect them. Keep the casualty quiet. Basically, you don't want them panicking, flapping around and moving their limbs a lot. So the more calm you keep them and the flatter you keep them and the less movement, the less they're likely to aggravate the situation.
Or a knuckle sandwich.
Yeah. Administer 100% O2 if you've got it. So the only real first aid tool as divers that we have is the O2 set. And this has the advantage that it increases the nitrogen pressure gradient, i.e. you're pushing gas into the circulation, which has got 0 nitrogen in it, and there's a high load of nitrogen in the tissue, so the nitrogen will move quickly into the bloodstream. So you eliminate it that way. You have the advantage of oxygenating the blood. So where you do have issues of restrictions in circulation, you're supersaturating the surrounding tissue with oxygen. So that's one of the advantages of giving oxygen early, is you're reducing tissue damage downstream of any obstruction or any bubbling, or as close to downstream as you can get. There we go. Treat for shock. I can see someone smiling in the background. The other point I mentioned earlier is that 98.5% of the oxygen is carried in the hemoglobin. So we'll come back to that in a minute. And as I said, we've got a first aid treatment, which is the oxygen, but it's not a cure on its own. So if we are treating someone for DCI, the only proper medical resolution you're going to get is if you evacuate them to a recompression facility, and they will make the determination then whether they're going to need to put them in a recompression chamber and take them down to a simulated depth on high O2, or whether they'll be able to do it without actually using the recompression chamber. So, any questions? Okay, burst lung, which basically is a overpressure injury. You know, we mentioned earlier people holding their breath and potentially shunting bubbles of gas into the bloodstream through the lung, through the alveoli. This is likely to have occurred or will have occurred if you have a burst lung injury. Now, although we describe both emphysema here and pneumothorax, which are two different lung-related injuries, we aren't really going to be able to determine which is which. And basically, the treatment is quite nicely the same. So they can occur in isolation, but are usually accompanied by an air embolism, because you basically stretch the tissues of the lungs until something's burst, and generally that means you've also forced gas into the bloodstream at the same time. So, signs and symptoms include chest discomfort, pain and bloody froth, i.e. foaming at the mouth, shortness of breath. Funnily enough, if you have only partial lung use, your breathing isn't going to be normal. Changes to vocal tone, crepitation, that means like stretched skin, almost like paper-like skin at the top of the neck. And somebody's favourite, shock. Unconsciousness and death. There's a cheery note to end on. As I said, and also you're more likely to see decompression illness because fast descents are going to promote uncontrolled release of nitrogen. So you're more likely to see the other symptoms of decompression illness as well. So, on-site first aid. Have them run around in a big circle going, help me, help me, help me. No, lie them down flat. Keep them quiet and relaxed. Administer 100% first aid, oxygen, sorry. And again, this is going to assist in getting rid of the nitrogen that's in the bloodstream. It's also going to compensate for loss of effective lung use. So if you're only down to one lung, you're getting 100% oxygen instead of 21% oxygen. Treat for shock. Sorry, I keep seeing Ruby out the corner of my eye, and I keep seeing the smile get wider and wider every time shock comes up.
If it helps with emphysema, I'm assuming this is like surgical emphysema.
Yeah.
You can tell that if someone's got it. So normally surgical emphysema is from a pneumothorax. If they've got it, you've got to cack your pants, and it's actually like bubble wrap under the skin.
Right.
And it normally starts up around here, but it can literally go everywhere. And it is a proper shit your pants moment.
Okay, well that's reassured me when I have to give first aid.
So if they've got to that point where it starts to bubble, it's not great. They do need an airlift out.
Yeah, well, to be honest, we're going for an airlift really early.
Yeah.
And again, evacuate to a recompression facility as soon as possible. One of the reasons for this is that almost in all of these injuries, you'll probably have got DCI. And the only way you're going to treat the DCI is in a recompression facility. So it might be great to take them to a hospital, but they've got complications beyond norm, if you like. So recompression facility all the way. Near drowning. Guess why we call it near drowning and not drowning?
They're not dead.
They're not dead, yeah. Causes. Respiratory interruption due to fluid inhalation. That includes beer. Signs and symptoms, i.e. the circumstance, the environment. So if they are underwater, in the water, floating on the surface of the water, and they're not conscious and not responsive, there's a high risk of a near drowning incident. They're not breathing, generally. Cyanosis, which is an ashen grey or blue appearance. Basically, the very pale, you look like death statement.
Gareth, yeah. It's all about near drowning, but
yeah,
if we bring somebody up,
yeah,
we can't pronounce them dead.
No,
even though they are dead.
Right.
They've got to be pronounced dead by somebody that is qualified to say, "Oi, you're dead."
Not dead till they're warm and dead.
Right. So yeah. I was just saying, what you're saying is doesn't matter whether they're dead or you assume they're dead. You still got to assume that it's a near drowning.
Yes, and if you speak to John Finch, I did my O2 course with him many moons ago, and they pulled someone out of the sea who was a recreational swimmer, just someone at the beach had gone for a swim, got into trouble, and he was spotted and dragged out of the water, and they gave AV and CC to him, or this individual who they thought was dead. They just thought, well, we'll do it. There's no hope. We'll just do our best. And that guy actually recovered. So, and he said he would have sworn the person was dead, but they did their best, and as it happened, it all had a positive outcome. So his point was, even though things look pretty grim, you just crack on as best you can, and you wait for the medics to turn up.
Yeah, so for us, I think if someone's submerged for more than 90 minutes, we consider not starting.
Yeah.
Basically, you're not dead, so you're warm, dry, and dead. So no matter how long you've been submerged for, you give it a go.
And cold water's beneficial because it
definitely
reduces the risk of brain injuries, etc. Which, funnily enough, is what we dive in. So, whoopee! Thumbs up for cold water diving. On-site first aid. Rescue breaths, generally, because they're not breathing. Enriched oxygen, if possible, which we've got an O2 set, we hope. And again, concentration of the oxygen reaching the casualty's lungs hopefully will offset any loss of lung use because there's fluid in them, etc. Chest compressions if required, and put them in the recovery position. There's going to be an awful lot of draining of fluid out of them. So position them so that they actually will drain rather than leaving them laying on their back. And evacuate to medical attention.
Robin, what are you doing?
Hang upside down again.
Oh.
Drain them out.
Yeah, evacuate to medical attention. Even if apparently fully recovered, because what they call dry drowning is a really, really big risk with anyone who's taken in a lot of water at any given time. So, yeah, make sure you evacuate them. I can see a finger raised.
Secondary drowning doesn't exist anymore, but it's only recently.
Oh, okay.
It's just drowning.
Okay.
It's just later on. But that's only like literally started to be changed like a couple of months ago.
Okay. Shock. Just for you, I've got shock.
Excited.
Inadequate circulation leading to tissue damage due to inadequate oxygenation and waste removal is the definition we've been given. Present to a greater or lesser degree in all injuries, which is why you see people faint when they hit their thumb with a hammer or something similar. Mechanisms. Reduced blood volume. Really, there's a number of different types of shock. There's septic shock, which is generally relates to poisoning or allergies, etc. And we're less likely to come in contact with that unless we go somewhere nice and warm with pretty fish that are poisonous. So there's septic shock, neurogenic shock, which is nervous system issues, anaphylactical shock. I didn't even say that right. Anaphylactic shock, which is allergies and poisoning again, I think. Cardiogenic shock, which is generally heart circulation problems. So when people are having heart attacks, they suffer from shock because it's cardio-induced. Hypovolemic shock, which is generally due to too little fluid. So if you chop someone's arm off and the blood's splurting out, they're likely to go into shock because they actually lose fluid. And that's where burns come into it as well, because you lose a lot of fluid when you get a very bad burn. And the other one, which you can get in diving, is immersion shock. And immersion shock is unusual in that you need to keep the casualty flat when you move them. But I think we come on to that in a minute. Massive dilation of blood vessels, so drop of blood pressure results in quite often fainting. And as I say, that can actually be the person standing next to the person who's actually the injured party. The other one sort of goes, plop, and you're dealing with them as well. As I said, inadequate cardiac output. Allergic reactions. Okay. Signs and symptoms. Weakness and dizziness. Pallor and sweating, either go pale, got a cold sweat. Rapid pulse rate, rapid breathing, feeling breathless, and unconsciousness. Oh, that jumped on. Sorry, it's a slight delay between me going next point and the thing reacting. On-site first aid. Treat the primary cause. So if they've lost a limb, rather than treat them for shock, deal with the blood loss and stop the blood loss. Reassure the casualty, TLC. As we know in this dive club, we're very considerate and kind and genuine and offer lots of positive encouragement and TLC all the time. Keep the casualty quiet. Lay the casualty down with the legs raised if they're not suffering from burst lung or DCI. And again, that pools the blood in the center core, which is where it's needed. Keep them warm and comfortable. Administer O2. Funny enough, it's an O2 course, so it comes up. And again, the increased oxygen will offset any negative effects through lack of circulation that the casualty might have. It's another person being admitted. Ooh. I've not moved on to the next slide. Hang on. Ah, there we go. Monitor condition. So if you're treating someone for shock, just don't leave them to their own devices. And nothing by mouth except for those suffering from DCI. And again, that was something that Paul mentioned when we were talking about using the O2 sets. And evacuate to medical attention. If it's just a case of lightheadedness and fainting, perhaps, and you're not necessarily going to do it, but probably shock is accompanying another injury or another issue. So shock is normally a secondary effect to what we're dealing with. Immersion shock, as I said, is a bit unusual. And this is an issue from being immersed in fluid for a prolonged period of time. So as an example, if you lose a diver and they're bobbing around on the surface for 6 hours and then you recover them, they're likely to be suffering from immersion shock. And one of the problems is normally your blood pressure is sustained by the muscles and the blood vessels contracting to give you a positive blood pressure. When you're supported, when you're in the water for a prolonged period of time, the water's exerting that pressure. So all of the systems of the body start to relax. And if you just pick someone up vertically out of the water, basically the blood just disappears from the head, past the heart, and ends up in their feet, which is not a good thing. So they need to be removed from the water prone, as in horizontal. Else it can be very, very bad. And for those of you old enough to remember the Fastnet race, it was a catastrophe when they lost no end of yachts. They got most of the people who sunk out of the water, but they had a huge loss of life because they were all suffering from immersion shock, or a large proportion of them were. And at that time, they used to lift people vertically. And that changed the way they reacted to people being in the water. They changed to lifting people horizontally after that.
Yeah, effectively, they were alive when they were in the water and dead by the time they got into the helicopter.
Yeah.
Because all the blood from the central core went to the feet.
Yeah, absolutely. So you keep the casualty horizontal at all times. And again, discourage any movement at all, really. And you're going to evacuate them to proper medical care. Carbon monoxide poisoning. Causes basically contaminated breathing gas. So the stuff you're breathing from the cylinder being contaminated. And to give this some context, a 0.1% carbon monoxide dose in a cylinder, on the surface, it will take you about an hour to notice any adverse effects from it. At 40 meters, you'd be dead before you hit that depth because of the partial pressure of the carbon monoxide. So contaminated gas is a really big issue. Carbon monoxide combines about 200, 300 times more readily with hemoglobin than does oxygen. And if you remember, I said 98.5% of the oxygen carried in the bloodstream is carried in the hemoglobin. So you can imagine if you've got carbon monoxide poisoning, you have significantly reduced the amount of oxygen that's being carried around to the cells and the tissues in the body. So the only mechanism we've got to fix that is to use oxygen as a 100% breathing gas to try and offset that effect. And it acts as a cellular poison. So, signs and symptoms. Number one, remove them from the source of contamination. That's treatment, sorry. Signs and symptoms: headache, pale or greyish appearance, weakness, dizziness and nausea, tunnel vision, vomiting, rapid pulse or rapid and thready pulse, poor pulse, rapid breathing, coma, convulsions, and ultimately death. They used to say you go cherry red, but that apparently happens very late on. You've got a really, really high dose of carbon monoxide by then. On-site first aid. Remove them from the source of contamination. Lie casualty down with the legs raised. Administer 100% oxygen or oxygen-enriched rescue breathing as appropriate. And as I say, we're now into the position where the fluid itself is the thing carrying the oxygen rather than the hemoglobin. And there's limited assistance in breaking down the carbo-oxyhemoglobin bond, chemical bond that's going on. Really, the only proper treatment is a recompression facility, hyperbaric oxygen. Ooh. And we get to the summary. Basically, every diving related injury, giving O2 is going to have a benefit. So from our point of view as non-medically trained divers giving first aid to a diver, it's quite simple. If you have a diver with a problem and you've got them back on the surface, put them on the O2 set and contact the medical people. 100% oxygen will provide the maximum benefit. Administer the oxygen as early as possible. And as Paul said a couple of weeks ago, if you haven't got 100% oxygen, these days we carry nitrox on the boat quite often because people use it as a diving gas. And that's got a higher percentage of oxygen, so you default to that. Oxygen is a supplement to the other first aid procedures that you're giving, and they increase the effectiveness of the other first aid that you're giving generally. Casualty must always be evacuated to the appropriate medical aid as soon as possible, irrespective of any apparent resolution of their condition. Now, from our point of view, Coast Guard is generally the fastest way we're going to evacuate an injured diver. The Coast Guard do a coordinating role, so they'll get you lifeboats, helicopters, ambulances, etc., all rolling and get them to you. But as importantly, they are also aware of which chambers are readily available and which chambers are occupied. So although you might be in Plymouth and the nearest chamber is in Plymouth, they will know if that Plymouth chamber is full and they're going to move you somewhere else, like Poole or London. So actually talking to the Coast Guard is far more beneficial in many ways than just phoning 999 and saying, can I have an ambulance? Ooh. And one other little point, we've got some instant management forms in the branch, which have now been put with Alex's assistance onto the forum. And on those, we do have a few little prompts and aid memoirs for if you have a diving injury, the ABCs of first aid, and DCI neurological symptoms and the required first stage, and basically a checklist and thing to work your way through. Any questions?
No.
It's worth mention how you can get carbon monoxide into your breathing air.
Well, carbon monoxide, if you're going to get it into the breathing gas, is generally because the compressor was either A, poorly maintained, or the inlet to the compressor had a contaminant feeding it. So portable compressors and the like, if they're near an exhaust on a vehicle or the exhaust of the compressor, they're going to be cycling burnt gases into the inlet, which is going to be put in your cylinder, which is not a good thing.
Or on a boat.
So,
The
or
exhaust
on a
from your
boat, yeah. So, yeah. So generally, the reason we're paying for air is that we want air of a particular quality being given to us, and keeping it clean is of prime importance.
Just to jump in there on the documentation, when you log into the forum, if you scroll right the way down to the bottom of the page, at the bottom of the forum, I've put the documents there in sections so that you can see what you're after.
And Robin's got a little map of our nearest and dearest chambers
Just
in
one
the UK.
moment, and I will bring it up. There we go. All see that?
Yeah.
And fully enough, that doesn't cover the one in Ireland, or the ones in Ireland, but yes.
That's the one in London.
Yeah,
That's the one in the Midlands.
yeah,
I think that one's at Great Yarmouth,
yeah,
Plymouth,
yeah.
Weymouth. Was it Weymouth or
Poole, I think. It's either
Poole,
Poole or Portsmouth.
Liverpool? That would be,
Oh,
Hull.
Oh, yeah,
yeah, Hull.
Poole, yeah.
Hull.
You need Paul for a proper northern accent there.
That's Portree.
Oban, isn't it?
Well, Oban, Portree, that way, isn't it?
Yeah,
That's Stornoway. No, not Stromness.
yeah.
And that one there, of course, is
Aberdeen.
Aberdeen. Going back onto the oxygen, the enriched oxygen.
Yeah.
It's obvious, I would say, but maybe not to some of the people that are just coming in. If normally, if somebody comes up and they've, let's say, broken a decompression stop or done a rather rapid ascent, it's normal that you'd put them on to oxygen straight away. You can either do it through the oxygen kit, but they could also be put onto a higher, if you haven't got enough there, you can also get them to breathe O2 at the highest level that you've got. Because you can't connect a normal diving cylinder to your oxygen cylinder, to your
O2 set.
the O2 set, unless you've made an adapter that you can do it. But even then, it's going to be a bit of a job. So they would need to be at that point conscious and able to breathe on a regulator. Is that right, or don't you?
Yeah. No. The other thing is that generally you're going to have a cylinder with a regulator on it to hand, whereas somebody might have to go and recover the O2 set and sort all that out for you. So that's at least an immediate thing that you've got immediately to hand that you can use.
Well, the best thing, of course, is a CCR, isn't it?
Yeah.
Rebreather. Stick them on that. Yeah.
Any questions?
does carbon monoxide have a taste, or is it tasteless?
Tasteless.
So you
Yeah,
wouldn't even-
tasteless is,
No,
I
you don't know.
understand it. I think it's just one of those cases you are aware that you're not feeling very good.
Yeah, fair enough.
I mean, carbon monoxide, that when people have barbecues indoors or
Yeah,
their flu's not
intense.
working, they just fall asleep.
Yeah, I mean, I think we've been up to the London hyperbaric facility to do a sort of what they call a test dive in the chamber, and they give you a whole run through. And one of the big things that they deal with is carbon monoxide poisoning from people with barbecues in the house, and it's a regular thing for them. It's not unusual. It's like, oh yeah, normally you can't get in the chamber because we've got someone on who's had a barbecue in the house and suffering from carbon monoxide poisoning.
Surely.
Last year there was a number of people who died because they were having barbecues outside while they were camping, and then took them inside their unit, their awning, to keep them warm.
Keep them warm.
And basically they suffered from the poisoning. And quite a number of people, well, I say number, several people died. So now most of the camping club organisations have warnings everywhere not to bring your barbecues indoors or undercover.
If your cylinders are being filled from a reputable retailer or dive centre, chances of carbon monoxide are very, very small. But what happens is that, you know, people have got portable, especially petrol-driven portable compressors, or their compressor, their air inlet is near a source of carbon exhaust, etc. And that's when you will get it. And especially if it's like a portable where they're not doing the tests regular, then, you know, because they have to do tests on the air quality on any compressor on a regular basis. I think it's once a month for a club compressor, maybe not here, but it was abroad. So every month we had to do a complete test on the air in the cylinders and from the compressor. So that route, it's you know, from a normal field point of view, it's very, very slim chance. But it can be if the inlet of the air inlet for the compressor has been placed in an inappropriate place. I don't think you can get it for somebody standing outside the air inlet smoking a cigarette.
Alex.
Well, they should.
Sorry. I was watching the smoke waft away from you earlier. So.
Well, my little compressor has got a snorkel about a meter, nearly 2 meters tall. So when I'm running the compressor, one, I make sure it's blowing away from the intake, but it's way up in the air, so I'm not going to suck in any exhaust gases.
You'd be surprised how many people stick the bloody inlet close to the exhaust, you know, because it's convenient or something like that. Or running a portable compressor inside the back of a van. You know, that's also a good one.
If we've got a failure of an oil ring or something like that in the compressor and we end up with oil on there, is that a cause of carbon monoxide poisoning as well? Or is that something
oil itself, it's normally, that actually damages your lungs. You get oil vapor into your lungs, which is...
That's a taste job, Paul.
Yeah,
we would taste that. Yeah, exactly.
But maintained compressors with bad oil in them, sometimes the oil will actually burn. Basically, it will burn itself. So that will be a cause of contamination from the oil in terms of the oil breaking down inside the compressor.
Most compressors are synthetic anyhow, synthetic oil. So they're not. They don't have a carbon. Very, very few have a carbon. In fact, nowadays, I don't think any of them have got a carbon-based oil system.
Mm-hmm.
And if they're doing O2, you know, if they're doing
nitrogen filtering,
then you know, instant mixing, then they really cannot have a mixed lubricating system. They have to have a sealed lubricating system. So it's very, very. I'd say it's very, very slim in this country to witness contaminated air with CO2.
We did a dive in Ireland, Southern Ireland, several years ago, and Andy Mellors and myself were buddied up. We jumped in the water. The cylinders were filled by the dive centre. He jumped in the water and he reckoned that he could taste oil within a matter of minutes or seconds actually hitting the water. So he actually came up on my pony cylinder because I filled it myself. So he went down on local air and came up on Paxton air.
Did they find anything then with that, Des? Was there a problem with anything? Or?
Oh, he mentioned it to the centre and they did a test and they said that they could find nothing wrong. But Andy Mellors swore blind that he had contaminated air.
I know we have had at least one case in the past where like half the cylinders were good and half the cylinders were bad. But to be fair, that was in the times when we were all diving air exclusively. And one of the advantages of us using nitrox much more now in dive centres producing nitrox is they do double filtering. So if you have a catastrophic filter failure on the primary filter, the secondary filter there's as a backup. So that issue is not as significant a problem as it used to be.
And likewise, I mean, if one of the buddy pairs is tasting an oily fill, then if they've been filled from the same fill station, both buddies will have the same problem. Yeah,
I mean, potentially. The issue we had was that I think that the filter must have failed halfway through filling up, the 12 cylinders or 24 cylinders we'd presented to the station.
Right.
So, of course, 6 people had good air and 6 people had bad air, basically.
Mm-hmm.
So, yeah, but that was in the days, I say, of single filtering.
But, I've had this out with a few, when they say, what do you want, clean air? And I say, well, your air should be clean anyhow.
Yeah. Well,
and they say, oh, no, you know what I mean. So you get the non-double filtered. But nowadays, a lot of them are, because, as you say, they're using, especially when they're using partial pressure blending, they've got to have a double filter system. Because they can't risk putting even a trace of oil into that cylinder if the first gas that goes into it when you're making the mix happens to be 100% oxygen.
Yeah.
But I can't really see the logic behind it. If you've got a commercial setup, you're testing your air on a regular basis. You have to, and there are limits to what is acceptable for, let's say, air breathing, and another limit to what is acceptable for nitrox mixing. But of course, with nitrox blending now, where you actually blend at the compressor inlet, you've got a bit of a problem. Well, you haven't got a bit of a problem because the problem's taken out because you're never actually seeing anything like 100% oxygen in that cylinder.
Yeah. One other thing I was just going to say for those of you, I think some of you have noticed that these have been all dive leader slides that we've been using. And some of you are still either just starting sports diver. The O2 course is a standalone course which overlaps with the diver training. So if you're doing the O2 course you don't even have to be a qualified diver to do the O2 course. So they take the slide set that relates to it from Dive Leader, and we use that as the teaching medium. And then there's a whole block of practicals and so forth that we bolt on as well. And that's a standalone course that, as it happens, is part of the Dive Leader program. So if we get to finish this off when life returns to normal, we can get you all qualified for O2, which from my point of view is a huge benefit, because I really don't care whether you're a dive leader, a novice, or just happen to be the bloke driving the boat. If I need O2, I really don't care which qualification you've got, as long as you give it to me.
And the other thing to bear in mind is that if you do the O2 course, once you've successfully completed that, then all of that topic signs you off for a big chunk of your dive leader course anyway.
Yeah.
So you don't have to repeat it when you do the dive leader course.
And generally, it's a bit more upbeat, the O2 course, because we normally do it as a day.
Yes.
So we give you this doom and despondency and how we're going to kill you. And then we do a whole block of, how we're not going to kill you. And at the same time, you get to be Hollywood actors playing casualties all over the place. So by the time you leave, you're in quite a positive mood rather than leaving this lecture going, oh my God.
Why would I want to do this?
Yeah.
It's also very beneficial to the club to have as many O2 trained divers as you possibly can. Because
yes, I've been on a few boats where they've said who's O2 qualified, and
yeah.
there's been 1 or 2 people.
In worse,
We've
the
had a few
casualty.
guests on our boat where someone said, how many people have O2 qualified? And we've looked up and go, I think everybody standing on the boat holds an O2 qualification. So, as I say, it's hugely beneficial because A, you know what to do with the set if someone else is involved, and B, you know what the hell is going on, and you can contribute, even if it is saying sit in the corner and shut up to somebody else.
Yeah. If you're in a club that's rich enough to have a hard boat of their own, where you can do a longer trip, and you've got a dive manager or a dive marshal plus a standby, and they split the dive and one goes in and the other one stays on, and then they swap over when the first one comes up. If you've only got one O2 trained person to back up, you cannot be dive manager or you can't be dive manager or dive marshal if you've got nobody to assist you. So if the other guy's in the water, you're taking charge of, let's say, a rescue or an incident, and you can't do many jobs. So if you've got somebody on there that's O2 trained, you can delegate straight away and say O2. And then your job will then be get the O2 gear ready, set up, so when we get the person on the boat, we can administer O2 straight away. So you become a very useful member, let's say, of the dive party.
Even me.
What?
Sorry?
Even me.
Yes,
Even you, yeah.
Tom Hardy's, whatever it was.
Andy.
Ruby, you're always useful.
Thanks, I don't know. Just a pretend paramedic, really.
From that little presentation, we were saying there that, the symptoms can occur in less likely cases about 3 hours after the dive. Sorry, there's a burglar alarm going off behind me. 3 hours after the dive. So...
Yeah, I thought it was outside.
Oh, is it you or me? I'm sure it was me.
I don't know.
So you could be back ashore, like we were down in Plymouth in the summer, all chilling out, eating ice cream and getting dolled up for the night out. And that's when someone's symptoms come on, which is one of the reasons why we take our sets down, even though the boat's got a set. Yeah. We'll quite often leave the set up in one of the rooms because then it means that if someone comes down with symptoms in the evening after diving is finished, when we're all chilled out, then we can treat them before we get or while we're getting the medics involved.
Yeah.
Rather than it's locked in the boat and Danny's gone off, or taken the boat out to get refuel it for the following day. So that's one of the reasons why we tend to move the O2 kit back to the digs when we finish diving.
And it's also important to know who's carrying it on the way home as well.
Yeah.
So that if anybody does start to have a problem, then we can always call them straight away to back up. And
so if you're doing a day dive, right, and you finish the day dive and you've had an incident, it's not a big incident, right, and you've had somebody who thinks they may have had a bend or a mate, etc., but they've not got the symptoms, severe symptoms or whatever, to say, yeah, let's get them to the right? So you report it, but you always say to them, or we used to say to them, right, I will ring you when you get home, and I will ring you in the morning. And if you find that you have anything at all that you're not sure of in the next 24 hours, and it doesn't have to be 24 hours because it can be longer. You know, it normally isn't, but there's no time limit of when those symptoms can actually develop. Because remember, what you're talking about could be just bubbles going around the bloodstream, and they might go round okay until all of a sudden they come to a point in the system where they don't fit, and that's when you get the clot or the blockage. But it might take a little while for that to actually get to wherever it starts, if you see what I mean. And so there's no actual time limit on it. So if somebody has actually, or you feel they may, is you keep in touch with them for some time and just say to them, if you feel ill or you feel not quite right, then call me and we'll organise getting you to a decompression unit.
I know we took someone down to the London chamber because they were convinced they were bent and they had a rash. We got them down there, and they'd been diving at Gildenberg, a 6-metre dive, which is why we all thought it was very unlikely. And the medics got them and poked them and then prodded them a bit more and then poked them and then went, yeah, stinging nettle rash.
Ollie Noonan.
So, yeah. But at least we'd take, he was there, he was in the right place. If it was a problem, they would have stuffed him in the chamber and sort of pumped him down. The denial thing is a real big issue with divers. I mean, partly because any of you who've been on a boat, if the seas are even slightly lumpy, you bump around on the boat and you crack your leg on something and you skid across the deck and hit your elbow on someone else's diving set. So by the time you get off, you're covered in aches and pains and bruises anyway. So that's a masking issue with some people. But these days, I think we're much better at saying, we really don't care if you've been bent or not. It's not going to stop you diving necessarily. So get yourself checked out. Whereas in the old days, I think a lot of people were frightened of either the macho thing of, I'm not going to admit I've got a problem, or if I say I've been bent, they won't let me go diving. And I think a lot of the top end divers, these days will now admit that, yeah, I've been bent. I think, I can't remember Jill, is it Henrith, the Canadian
cave diver,
underwater naturalist, she does a lot of stuff. She got herself bent in Mexico.
one of the cenotes.
Yeah, and she said it was only after she got bent and had been treated that people would come up to her and go, oh, surprised you admitted to that, but yeah, I've been bent a couple of times as well. But don't tell anyone.
Yeah, because to think that it's a bad reflection on your ability to dive is completely wrong, because it may be you picked the wrong day to dive and your system wasn't quite functioning the way it would normally, and you've picked up maybe just a little bit too fast an ascent, which normally would not matter, but on that day it does matter. But you won't say nothing because you don't want people to think that which is absolutely stupid, but we all go through it. I don't want to say nothing because that means I won't be able to get in for the second dive, and I want to do this, and I don't want to let people down. But something goes wrong when you go back down in. There was a thing going around when I first started that they said, "Oh, if you've got a bed, we'll take you back in the water down to the depth, the deepest depth that you went, and then we'll bring you back up again."
Yeah, it's the same as bed.
That's what she did in the cave, I think.
Yeah, it's
as a novice diver, you think, "Oh, okay, well, he knows all about it."
Yeah.
But you wouldn't do that. You just don't do that sort of thing.
It's
Yeah,
the
that's
same
what
as bending your computer.
Yeah.
Just stick it on a fishing line. Send it back down.
It's not like clearing your ears. This is a little bit more scientific than I can't clear my ears, so I come up a little bit and I go down again. Now, if you've got DCI, you've got DCI, and you don't muck about with it. You know.
Some of you may remember one of our old members. I won't mention his surname, but Graham.
Yeah.
He had a mild bend, and his dive profile was potentially perfect. But when he was back on the surface and he bent down to work on his kit, he basically threw a wobbly, and it turned out he had a mild bend.
He should have been wearing slip-ons. When he went to tie his shoes up, that's when it went, wasn't it?
Yeah, exactly.
I've got to run away now, so
Yeah.
cheers, Robin. Cheers, Gareth.
Right.
Okay. You've
Cheers,
got to
John.
remember that
Hi, John.
all the decompression computers do is they run a mathematical model of how the physiologists think perhaps maybe the body works. It's just a mathematical model, which was they sort of kept chucking people in and went, oh, that one bent, that one didn't bend, that one bent, that one didn't bend. So it's not a perfect representation of the human body. It's a mathematical model, and it's got imperfections in it. And every year they come up with another theory about another wonderful thing that's going to make it better. So, you know, you've just got to accept there's a degree of unknown involved. It's pretty damn good because we don't get many bends, but it's not a perfect model. And it can never perfectly model each individual on every day of their lives. Sometimes they'll have a drug in the system, you know, even an aspirin or something. Sometimes you'll be dehydrated. Sometimes you'll be stressed. All those things are complementary factors. So just you treat it with a bit of care, and when you do get symptoms, you actually pay a bit of attention to them and say to somebody, and you need really to say to somebody else, I don't feel quite right, and let them start to make the decision. One of the big problems, Jill said this in one of her presentations, one of the big problems is that because she's at a perceived level, nobody will take over. She has to literally give the authority to somebody else to say, I am not feeling right. And you could have a neurological bend, which funnily enough means your brain might not be working quite as well as it might. So you really want somebody else to take on, be your advocate, take on the responsibility of looking at you and making decisions for you. And that, in her case, she said that actually followed her all the way to the hospital. She needed someone to fight the medics and say, this is a decompression injury. Mm-hmm. This is a bend. You need to get hyperbaric treatment for her. You need to phone this number of the hyperbaric specialists. Otherwise, they'd have just parked her in the corner and said, well, we'll get back to you a bit later because you've got a bad elbow or a bad ankle.
Well, hopefully when we have some form of normality and the hospitals can cope, we'll try to get a dry dive to the chamber, either the one in Birmingham or the one in Whipps Cross, for people who haven't been before, just to give them knowledge to gain the experience. And my view is one of the key things to say, well, there's nothing to be afraid of. So this business of denial hopefully will go away. Yeah,
I think one of the big benefits of doing the dry dives is at least when they wheel you in, you kind of go, I know what's coming next. You get a nice little smock. Exactly. And they wheel you into that chamber and you wear this big mask thing.
Exactly.
And there's a whoosh sound.
Yeah, and you freeze your goons off.
Sucky sound while they pump you down.
Yeah.
Gareth's bare bottom.
Yeah, and it gets bloody hot.
And it gets bloody cold on the way back.
Yeah.
It might be a good idea to maybe try and organise a club trip to one of the chambers in the Midlands.
I just said that.
Oh, did you? Sorry, I'm not listening.
With a programme. With a programme. Yeah, I mean, either the one in the Midlands or Whipps Cross. We've done Whipps Cross a couple of times now. When things get back to the reasonable normality, and and the hospitals are not under pressure, we can probably deal with that. The thing is with the organising this, we did the Whips Cross one, and it was all there. We actually got down there and found that our trip was cancelled because they had an emergency. So, you know, it's one of those things. They're not cheap. I think it's about 60 quid a head.
50 quid a head, yeah.
Yeah, to do it, but it's well worth the experience. And for those of you who've not done it before, you can take your computer in, you stick it in a bucket of water, and it actually records that as a dive.
Yeah.
So
So
you get what's called a dry dive. And it's well, you go down to about 40 meters.
And you'll feel knocked.
And you will be knocked. And they do tests while you're in there to see how well you can cope. They do the test when you go in to see how you do it, how you work on the surface, and then they check again when you're down on the bottom. And it's a good experience. The only thing with you ladies, of course, you can't wear any makeup.
Oh, God.
Really?
I'm not going then. Sorry.
I know Alex had a look of shock on his face because
Alex needs it though, doesn't he?
Yeah. Did anybody go down on the last one when oh Christ, what's her name? Lana. She was told she had to take her eye makeup off before she went in. She wouldn't go in. She didn't want to take her eye makeup off.
What actually happens then if you have makeup on?
It's a carbon based. So going in at really high levels of oxygen, her eyelashes could have caught fire.
Well, the time I went into a chamber was when I signed up for submarines.
Yeah, well, that's.
But nobody was wearing makeup then.
I don't believe it.
Yeah,
That came afterwards, Robin.
High heels, yes, but not makeup.
Who was it when and they would order you a Chinese in, but you couldn't have prawn crackers because of the oil in them.
Yeah, what they call it, stuff they put in the Chinese meals.
Yeah,
Monosodium glutamate.
Monosodium gluten. Yeah, well,
The MSG.
no, I think most of it was fine. It was just the prawn crackers in particular.
Oh,
They're
right.
quite apparently they burn quite well.
Probably great.
Sounds like Graham. Yeah.
Things you never knew before, eh?
Exactly.
Who knew, eh?
But if we organise it, I mean, basically, you can. I think it's the one in Whips Cross will take 16 people, so we can get 16 people drivers down there. Minimum qualification is ocean diver. You have to be signed up as an ocean diver, but other than that, and if you've got any medical issues, obviously you have to have your medical certificate to say you're suitable to dive.
Right.
Okay, I think that's it then, isn't it?
Yeah, I think it is. Yeah, thanks very much,
Thank
Gareth.
you.
Yeah,
Well,
thank
Gareth,
you.
thank
Want to
you.
say anything about your upcoming session?
Yes, it's going to be really